Welcome to the ACOEM Public Policy Briefing Conference Call. My name is Anna and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session. Please note that this conference is being recorded. I will now turn the call over to Patrick O'Connor. Patrick, you may begin.
Thank you very much, and good morning and good afternoon, depending on your time zone. For the next hour or so, I'm going to have the opportunity to review with you a number of advocacy issues at the federal level where ACOEM's been involved over the course of the last several months, and give you a bit of an outlook as to what's expected in the months and year ahead. This, of course, is a busy time in the nation's capital, clearly dominated by the tragedy of what happened in Paris last Friday. But in addition to that, Congress is also struggling with reauthorization of the federal highway program. That was supposed to have been completed by this Friday. That has been postponed now until December 3rd. That bill not only reauthorizes funding for the nation's highways and bridges, but also will make a number of changes to federal highway safety requirements. Congress is also in the midst of trying to resolve funding for the various federal agencies. That has to be completed by December 11th, or we again could potentially face the prospect of a government shutdown. And then this week, the Senate is looking at the possibility of exercising what's called the Congressional Review Act. Congressional Review Act allows Congress to actually veto a federal regulation that's been issued by a federal agency. This week, the Senate is planning to vote on Congressional Review Act resolutions that would block EPA's Clean Power Plan and EPA's rule that limits carbon output from new coal and gas-fired power plants. Once the Senate does that, the House will follow suit. In both cases, though, the President would have to sign a Congressional Review Act resolution, and that certainly will not happen with the White House. So there's a lot going on here in the nation's capital, and as we get into the holiday season, there are fewer and fewer days where Congress will actually be in session. With that being said, I want to move forward with the briefing and talk to you a little bit first about ACOEM's advocacy activities. ACOEM's advocacy activities are directed by ACOEM's Council on Public Affairs that is chaired by Dr. Bob McClellan from Dartmouth-Hitchcock. The Public Policy Council, in turn, reports to ACOEM's Executive Committee and to the President of ACOEM, Dr. Mark Roberts, and the Board of Directors. Public Policy Council meets via conference call once a month and then also meets during the AOHC. If you're interested in the Public Policy Council, feel free to drop me an email. The last slide in this presentation, we'll find my email address and my phone number. And I believe also that ACOEM will be sending a PDF out to the participants of this presentation. ACOEM's advocacy is built around what's known as Healthy Workforce Now, ACOEM's Action Agenda for Change. This is an agenda that the Public Policy Council adopted and the board approved. It's been updated twice now over the last 2 or 3 years. Just briefly, what this does is set out 10 goals for ACOEM's Agenda for Change. First is to establish a national culture of health in the workplace and ensure that every worker in the U.S. has access to occupational health care. Increase awareness and utilization of work disability management programs as a fundamental part of health improvement strategies. Promote workplace initiatives that help strengthen and improve the national public health and public safety infrastructure. Improve the quality, cost, and consistency of the nation's workers' compensation programs. And the last one on this screen, reduce health disparities in the workplace. The other 5 points on the agenda create stronger protections for workers through enhanced rulemaking and record-keeping policies. promote federal funding for OEM training programs, residency programs, include workplace health initiatives as a fundamental component of federal health policy, raise awareness in response to environmental health in the workplace, homes, and communities. This ties into ACOEM's mission of working on the health of the workers in the workplace, at home, and in their communities. And the last one, strengthen the practice environment for you to ensure that you're able to provide the full extent of your expertise to benefit the health of workers, their dependents, and retirees. So this makes up ACOEM's agenda for change, and everything that ACOEM does with respect to advocacy and public policy falls into one of these 10 objectives. One of the things that ACOEM will be doing beginning in 2016 is ACOEM will have an ACOEM Legislative Action Center. It will be hosted by an organization, Voter Voice. Voter Voice is the same vendor host that hosts the Legislative Action Center for the American Medical Association. Voter Voice will give ACOEM the ability to reach out to you on an issue-by-issue basis. We'll be able to provide you action alerts on both federal and state issues. It will provide a customized grassroots action center. So we'll be actually able to reach out to you, give you the text of a draft letter to send on to your elected representative. It will match you via your home or business address. It will match you to your elected member of Congress, or at the state level to your state representative or state senator. It will allow us to survey you on advocacy issues, on federal and state issues. It will also enable us to provide you tools so you actually will be able to comment on federal regulations and federal agency efforts. Again, we would provide you through the Legislative Action Center with a template that you can then edit and send on, in this case, to the federal agency. This will go live shortly after the first of the year. This slide just gives you an idea of what an action alert would look like that you receive at your desk. It would explain what we're asking you to do. In this case, it's to help support the wonderful bill. You would then compose your message. We would provide you a draft message that you would be able to personalize as you see fit. You can customize your signature, and then at the bottom you would enter your email address and zip code. Once you do that, you would hit continue, and the message would be sent on its way. ACOEM will have the ability then to monitor how many letters are sent, who they're being sent to, and so then we'll be able to follow up with specific congressional offices based on the responses that you folks sent in. Mr. Adam Campbell is not an ACOEM member. He is with Voter Voice, and he filled this out on a test run. You will have a chance to enter your profile into the system. You'll also note at the bottom that you'll be able to check if you want to receive further alerts or if you do not want to. So there will be an opportunity to opt out of the system if that's your preference. In addition to the Legislative Action Center, ACOEM also has its state advocacy community. You'll find this in the My ACOEM section of the ACOEM website. This was stood up a couple of years ago, and the goal of the state advocacy community is to allow members to exchange ideas, information, and strategies on how to address state issues. If you go on to the advocacy community site, you'll find advocacy tips, state information, alerts, how to contact your state medical society, your state legislators, workers' compensation officials, etc. And again, the goal through this community is for components and interested members to share information and best practices and have access to resources and discussion forums. the goal is to really facilitate this exchange. So a member in New York would be able to communicate with a member of California. If a component in Colorado is working on a state legislative issue, would be able to share their experience and their thoughts with components in other parts of the country. So I would urge you, if you're not a member of the advocacy community, go on to my ACOEM and sign up. OEM in the federal budget. As I mentioned, Congress is again in the throes of trying to address funding for the federal agencies. This is done within 12 different appropriations bills. Most of the OEM issues with respect to the federal budget are in what's called the Labor, Health, and Services funding bill. There, as you probably all are aware, there was a federal budget agreement that was reached between the White House and Congress just a few weeks ago. It increased spending by $1 trillion. Hopefully that will allow the federal government to remain open after December 11th. That increase is divided between 12 spending bills. The way the appropriations process is structured, there are 12 different bills that fund the various agencies. This agreement could potentially, and I say potentially because negotiations are still going on between the House and Senate, this agreement could potentially fully fund the ERCs, which is certainly important to ACOEM and OEM. Restore funding for the ag centers. The Senate bill would eliminate funding for the ag centers. Restore funding for the NIOS Total Worker Health Program. Again, the Senate bill eliminated funding for the NIOS Total Worker Health Program. Would increase funding and restore funding for HRSA's Preventive Medicine Residency Program. The House bill severely slashed the Preventive Medicine Residency Program funding, and the Senate bill eliminated it. It would restore funding for AHRQ. The House bill would effectively eliminate AHRQ as an agency. And the last point, it would fully fund CDC's tobacco prevention programs. The House bill severely limited the funding for CDC's tobacco prevention programs. ACOEM over the last several weeks has weighed in on each of these bullet points, both through individual letters that ACOEM has sent to Capitol Hill, but also in coalition with allied organizations. One of the problems in getting these bills passed by the December 11th are what are called policy writers. A policy writer is a non-funding measure that's added to an appropriations bill. And what these writers effectively do is they tell a federal agency that no federal funds can be spent for the following purpose, whatever that might be. There are more than 80 of these policy writers pending right now. And each of the policy writers is being negotiated between the Democrats and Republicans in the House and Senate. Just an example of these policy writers, it would block EPA's recent rule setting the ozone non-attainment standard, block OSHA from issuing a final rule on silica, defund Planned Parenthood, and grandfather e-cigarettes, effectively skirt FDA's pending e-cigarette regulation. Again, there are 80 plus of these policy writers. Not all of them will make it into a final bill, but several will. And so, as you can see, things like defunding of Planned Parenthood could conceivably still result in shutting down the federal government for at least a period of time. Regulatory activity, I want to just recap for you some recent regulatory activity that's been going on. OSHA, occupational exposure to infectious disease. They're still in a pre-rule stage on this. This would affect most physician offices, medical centers, hospitals, etc. They're in the pre-rule stage. Late last year, OSHA convened what's called a Small Business Advocacy Review Panel. ACOEM was represented on that panel through a member in California. But we're still in the pre-rule stage, and we're probably a long ways from seeing even a proposed rule on infectious disease. Occupational exposure to beryllium, a proposed rule was published by OSHA in August of 2015, and ACOEM submitted comments on that proposed beryllium rule. It'll probably be well into 2016 before we see a final beryllium rule, though. OSHA record keeping. About a year ago, a little more than a year ago, OSHA proposed that employers would have to electronically submit their illness and injury information on a regular basis. ACOEM participated in that rulemaking, testified at OSHA hearings, and submitted written comments. That final rule is pending. It's pending review by the White House and the White House Office of Management and Budget. Occupational exposure to silica, that final rule is pending at OSHA. OSHA is still working on reviewing the thousands of comments that were submitted on the silica rule, so it's going to be a while before OSHA submits a final rule to the White House for approval. And again, the silica rule is at risk because of the policy rider that's pending in the appropriations process. With respect to emergency response workers, in July of 2014, OSHA hosted a stakeholder meeting looking at what needs to be done to protect emergency response folks, firefighters, ambulance personnel, EMTs, etc., both in the community but also in the workplace. They're still trying to determine what their next steps will be with regard to emergency response workers. I also want to note that although it's not in the slide, OSHA has just released a draft document updating their safety and health program management guidelines. These guidelines were last issued, originally published in 1989. These new guidelines build on that previous version, as well as lessons learned from the VPP and the SHARP program. These guidelines, again, were just issued late last week. OSHA notes, though, that these are not a new standard or regulation and don't create any new legal obligation or alter existing obligations created by OSHA standards and regulations. These are voluntary guidelines. But the Council on Public Affairs will be taking a close look at these guidelines and submitting comments. Comments are due within 90 days on these draft guidelines. Moving forward, at EPA, they issued in October 1st, National Ambient Air Quality Standard for ozone. They reduced it to 70 parts per billion. ACOEM had submitted comments saying that there was adequate scientific evidence to reduce it below 70 parts per billion. Many others in the medical community had advocated for going down as far as 60 parts per billion. EPA took a middle ground position, setting it at 70 parts per billion, although that some would consider that a win for industry. Industry would still like to block this rule from going forward. With respect to FDA and e-cigarettes, FDA proposed a rule that would deem e-cigarettes, cigars, and similar products to be tobacco products. ACOEM submitted comments, and a final rule is pending White House review. Electronic health record and capturing industry and occupation information. This has been a priority project for ACOEM over the last 2 or 3 years to move towards requiring a certified EHR to have the capability of capturing I&O information. The Office of the National Coordinator for Health IT, the national coordinator, operates in the Department of Health and Human Services, published a request for comments several months ago on inclusion of work information in the EHR. The national coordinator asked for comments on the feasibility of capturing employment status, time-stamping that and linking it to the start date, collecting patients' history of occupation, and et cetera. Again, ACOEM submitted comments, detailed comments on this issue. ACOEM's been working closely with NIOSH on this over the last 2 years. The final rule was published in October 16th of this year. In that final rule, the national coordinator, and you'll see it on your screen, stated that the agency continues to believe in the value of I&O information to provide opportunities for healthcare providers to improve patient outcomes caused by work or health conditions whose management is affected by work, and reiterated that the long-term goal is for health providers to use I&O information to assess symptoms in the context of work activities, environments, inform patients of risk, and obtain information to assist in return to work determination, and evaluate the health and information needs of groups of patients. Unfortunately, though, and this is both a good news and bad news. They went on to say that given the feedback about the immaturity of the standards currently available for supporting these goals, they chose not to adopt a certification criteria for an EHR for the collection of I&O information. They note, though, that they're optimistic about the NIOSH-led effort, and again, ACOEM is very involved in that effort. And once that process develops a standard where there's a consensus around it, the national coordinator will consider it and for incorporating I&O in certification criteria in a future rulemaking. This, again, has been a priority of the Council on Public Affairs and ACOEM to get I&O information incorporated into a certified EHR. Again, ACOEM has avoided taking a position as to whether or not the primary care provider should be required to capture this information. At this point, the focus has been on the certification piece of it. Workplace wellness, this has been a priority for ACOEM for the last several years through the Council on Health and Productivity. The Affordable Care Act that was passed in 2010 provided the ability for employers to provide incentives to employees to participate in workplace wellness programs. However, the incentive provision that was provided in the Affordable Care Act avoided the issue of whether or not those incentives or how those incentives interacted with the Americans with Disabilities Act and GINA. So that was left to the EEOC to resolve. In April of 2015, EEOC proposed a rule outlining how the ADA applies to wellness programs. Those wellness programs under the ACA allows employers to offer incentives up to 30% of the total cost of employee-only coverage in connection with wellness programs. The EEOC went on to say that the program must be voluntary, and to ensure that it's voluntary, EEOC stipulated that it not require employees to participate, not deny coverage under any group health plan for employees who did not participate, does not take any adverse employment action or retaliate, interfere with, etc., with employees who do not want to participate, and provides employees with a notice containing certain information relating to the program. ACOEM submitted detailed comments on this rule, on this proposed rule. One of the things that I would point out is the EEOC would limit the 30% incentive or up to 30% to the total cost of employee-only coverage. it was our position, ACOEM's position, that the Affordable Care Act was clear that the incentive should be 30% of family coverage if the individual had family coverage. So this is one of the many areas where ACOEM differs from the EEOC proposal. Other questions, the EEOC proposal did not address GINA. So, we're not sure what would happen at the point a complaint's filed under GINA. Again, the incentives, the EEOC speaks only to employee-only coverage. There's also a question that says that if employer conducts a disability-related inquiry or medical examination, any incentive must be capped at 30%, even with regard to tobacco use. Tobacco is the one place that there's a 50% incentive provided for participation in a tobacco cessation program. But EEOC has taken the position if there's a disability-related inquiry or medical examination, the tobacco incentive is still capped at 30%. And it talks about reasonable accommodations must be provided for participatory and health contingent wellness programs. It's unclear what EEOC means about what kinds of reasonable accommodations would need to be provided. In response to I just got ahead of myself. Some additional questions. There's some question about health risk assessments, which merely solicit information from employees without an advice component, appear to be prohibited under the proposed rule because EEOC does not consider them to be reasonably designed to promote health. Number of undefined terms that are not in the what are called the tri-agency rules. Departments of Labor, Treasury, and Health and Human Services actually issued the rules implementing the wellness incentives. Several of the terms in those rules are not addressed in the EEOC rule. So we really have a conflict between EEOC, which has put itself in a position of interpreting what the other three agencies meant. There's uncertainty of whether similar incentives must be offered to employees who decline to participate in the wellness program, but because they certify that the employee is under active treatment by a physician for any at-risk condition. And last, again, there's certain uncertainty with reference to how wellness program-related claims under Title VII, the Civil Rights Act, and ADEA are to be handled. So a number of questions about the EEOC rule were raised by ACOEM and others. In response, legislation has been introduced in the Congress. It's known as the Preserving Employee Wellness Program Act, sponsored by Senator Alexander from Tennessee, who chairs the Senate Health, Education, Labor, and Pensions Committee, and Representative John Klein, who chairs the House Education and Workforce Committee. That bill would clarify current law. That current law allows for workplace wellness programs that encourage employee participation through financial incentives. ACOEM is supporting this legislation, as are many other health and employer groups. Affordable Care Act. Before I go to the next slide, let me just update you on the status of repeal of the Affordable Care Act. There is a lot of discussion here in the nation's capital about repealing the Affordable Care Act. The House of Representatives has already passed a bill that would repeal the Affordable Care Act. The Senate is considering using a parliamentary maneuver that would allow it to also pass a bill repealing the Affordable Care Act. The parliamentary maneuver would allow them to do so without running afoul of the filibuster. Under the filibuster rule, it takes 60 votes to move a measure through the Senate. The parliamentary maneuver, which is certainly appropriate, would allow a bill to be passed only with 51 votes. Senator Mitch McConnell, the Senate Majority Leader, is considering how to move this repeal bill. To do so, they probably will take out of it, though, the measure that would defund Planned Parenthood. There are a handful of Republicans that are opposed to defunding Planned Parenthood, and they possibly would vote against a repeal bill if that were included. At the end of the day, though, however, assuming the House and Senate do pass a bill to repeal the Affordable Care Act, it would go to the White House where the president would veto it. So any discussion of repeal of the Affordable Care Act is political posturing at its best. The one area in the Affordable Care Act where repeal is certainly possible is the Cadillac tax. This is the 40% excise tax to be imposed on high-cost employer-sponsored health plans beginning in 2018. Those thresholds beginning in 2018 would be $10,200 per self-only policy and $27,500 for a family policy. Legislation has been introduced to repeal the Cadillac tax. There are a number of issues with it. In a guidance document that the IRS issued, it stated that it anticipates that pre-tax salary reduction contributions made by employees would be subject to the tax. One of the concerns we had is it discussed the exclusion of certain health on-site medical clinics that offer only de minimis care to employees, that those on-site clinics would not have to be factored into whether or not the employer was meeting that threshold numbers. But it was unclear from the guidance as to what this IRS meant by de minimis and what types of care would be included in that. They also asked for comments on treatment of on-site clinics that provide certain services, including immunizations, allergy injections, provision of non-prescription pain relievers, and treatment of injuries caused by work. ACOEM submitted written comments on this guidance document. This will be followed by a proposed rule on the Cadillac tax, and then a final rule. Legislation, though, has been introduced to repeal the Cadillac tax. It's bipartisan legislation, which is the good news because it means that we're getting to a consensus between the Democrats and Republicans on repealing the Cadillac tax. The bad news is, though, that under rules of Congress, and yes, Congress once in a while does operate by rules, a repeal of the Cadillac tax would have to be offset by a revenue raiser. And the Cadillac tax is expected to raise billions of dollars, that's billions with a B, to fund the Affordable Care Act. So any repeal of the Cadillac tax would likely have to be accompanied by a way to offset or to raise the funds to equal that amount associated with the repeal. Moving forward, OEM residency programs. This, again, has been a priority issue for ACOEM over the last several years. How to increase funding for occupational medicine residency programs. As you well know, OEM is one of the few specialties that does not benefit from the graduate medical education program that is funded through the Council on Medicare and Medicaid Services. The federal investment in occupational medicine comes primarily from NIOSH and a little bit of funding from HRSA. That being said, we have worked closely with NIOSH over the last year on this issue, and as a result, NIOSH is going to convene an occupational medicine workforce summit in this coming June, and it will be held at a Johns Hopkins facility in Laurel, Maryland, which is right outside Washington, D.C. The objectives of the summit will be to bring together key stakeholders to identify challenges and barriers related to the recruitment, education, and training, board certification and placement of OM positions in the U.S. workforce and to develop an action plan to address these issues over the next 3 to 5 years. And this is a key objective to ACOEM, that this summit actually come out with specific action items to address the OM workforce needs. The goals would be to come out of the summit with an action plan to increase the number of residency-trained and board-certified occupational medicine physicians, increase the number and quality of occupational medicine residency programs, increase training resources, which means money for occupational medicine, leverage existing training resources. One of the things we hope will be that the various federal agencies that do fund residency programs will participate. Department of Defense funds has some monies available. Veterans Affairs has some money. HRSA, of course. NIOSH. We hope that Council on Medicare and Medicaid Services will participate. And then the fifth goal would be to increase awareness of occupational medicine. And part of this goal is to talk about how to increase awareness of occupational medicine at the medical school level to encourage graduates to opt to go into occupational medicine residency programs. The two issues that we've heard most from the task force that's putting this summit together, ACOEM's part of that summit, that task force, of course, but several residency directors are also part of it. And what we've heard from the residency directors is, one, that they need additional funding to support residents, but two, they need a stronger pipeline of graduates who want to go into their residency programs. Deliverables from this summit would be a report of best practices related to training, education, recruitment, etc., a report of recommendations, and then the action plan. Again, the action plan we feel is critical. We don't want to come out of the summit just with another report that goes on the bookshelf. Moving forward on prescription drugs, as I think you all know, we have an epidemic in the country right now with use and overuse of painkillers and opioids. ACOEM has been involved, is currently involved in three different efforts in this regard. One, ACOEM is a member of the AMA Task Force to reduce opioid abuse. Two, we're working with CDC on their draft guidelines for use of opioids in chronic pain. And three, ACOEM is a partner with HHS. We've entered into an HHS opioid provider partnership agreement. The AMA Task Force is made up of many of the medical specialty societies. It initially focused on urging physicians to register for and use the state-based prescription drug monitoring programs. We're looking at enhancing physicians' education on the safe, effective, and evidence-based prescribing, and doing a national marketing, social, and communications program to raise awareness of the steps that physicians can take to combat this epidemic. The AMA Task Force meets almost on a weekly basis, and again, ACOEM is part of that task force. The CDC Prescriber Guidelines, CDC will soon publish a new guideline for prescribing opioids for chronic pain. The guideline has not been issued yet for public comment. ACOEM has seen an overview of the guidelines, but we've not seen the entirety of the document. CDC has stated, though, that the development process they're using will meet scientific standards, include expert consultation, allow for appropriate stakeholders to provide input, and facilitate partnership development to enhance dissemination and uptake. Again, we're working closely with CDC on their guidelines, and ACOEM will be coming out with a position on the CDC guidelines shortly. The partnership, this is a partnership that HHS reached out to ACOEM and other provider groups. As a result of this, ACOEM has made a commitment to offer education and opioid provider training to all the members, to encourage members to register with their state PDMP, utilize communications to members to promote the prescribing of noxiclone, I can't pronounce that word, provide resources to all members making patient referrals to opioid treatment programs, and ensure that ACOEM members are exposed to public-facing provider awareness programs. ACOEM will be devoting a fair share of its resources to the opioid issue in the coming months. Value of prevention. We all know within ACOEM the value of prevention. Unfortunately, Congress, in its wisdom, has rules that really don't recognize the value of prevention. We have been supporting what's called the Preventive Health Savings Act. This was introduced by Congressman Mike Burgess from Texas. This would give the Congressional Budget Office, the CBO is a congressional agency that scores the revenue impact of proposed legislation. The legislation would give the CBO the flexibility to expand what's called the scoring window to 20 years when analyzing the cost and value of prevention-focused policy. By allowing the CBO to widen its scoring window and to evaluate the cost-saving potential of prevention programs, this legislation will give CBO the ability to provide a more accurate assessment of the long-term budgetary effects of preventive health programs. One of the things we ran into back during consideration of the Affordable Care Act, when ACOEM and others tried to insert prevention measures into the Affordable Care Act, is the Congressional Budget Office kept coming back saying, well, they don't have the ability to score the revenue value of those programs. And the revenue value, of course, would be things like an annual physical examination over a period of time lead to a healthier workforce. That's an overly simplistic example, of course. But right now, Congress can't do that. Congress can't look beyond 10 years. And the value of prevention, you really need to go beyond that 10-year window. Integrating safety and health, this again has been an area of significant focus by ACOEM over the last couple of years. ACOEM and the Underwriters Laboratories came out with a paper that was published in the May 2015 issue of JOEM. Within that paper, it came forward with a proposed IH index. And this index would translate the impact of employer health and safety programs into the business value for the investment community, measuring the effectiveness of employers' health and safety programs, similar to what Dow Jones does with respect to economic, social, and environmental sustainability. The basis of this is that the overall well-being of America's workers could be significantly improved through the adoption of a framework for integrating health and safety strategies in the workplace, including this use of a standard index for measuring the business value. This was preceded by a paper that ACOEM came out with about 2 years ago that talked about the value of integrating health and safety in the workplace, on the premise that a healthier worker was also going to be a safer worker in the workplace. Along these lines, the Institute of Medicine will hold a workshop in the first week of December, exploring shared value in global health and safety. The ACOEM UL paper will be one of the documents that will be used at this workshop. So again, this is an indication that there is increased interest in the employer community about integrating safety and health in the workplace. This, of course, dovetails nicely with what NIOSH has been doing with its Total Worker Health Initiative. Again, the objectives of the IOM workshop is to examine the relationship between the shared value of meeting health and safety needs of communities and illuminate the impacts and implications of this increased movement towards shared value. This is my contact information. Again, please don't ever hesitate to give me a call or drop me an email if I can answer a question or if you need additional information on some issue that where ACOEMs engaged, or you just like information on a federal legislative or regulatory issue that's come to your attention. With that, I will turn it back over to the operator to moderate our question and answers. And thank you very much for your time again.
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. And I show no questions at this time. I will now turn the call over back to Mr. O'Connor for closing remarks.
Well, thank you very much, and thanks to everybody for participating in this call today. Again, if I can ever be of assistance to you, please don't hesitate to contact me by phone or email. It's been a privilege to work with ACOEM and its members over the last few years, and I look forward to doing that in the future. Again, thank you very much for participating.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.